CMS is ensuring successful implementation of the exchanges through several methods. One method is obviously the website, which is healthcare.gov. Second is through the call centers, which are 24/7. There's a toll-free number. And then there are various forms of in-person assistance. One would be the Navigator program, and we recently awarded $67 million nationally to help. These are individuals who are trusted partners who have done this in previous programs such as Medicaid and CHIP programs, who will now be working to help people understand what health insurance is available and how they would go about signing up. There are also volunteers that we're calling counselors, and these are individuals usually hospital-based, but they can be in federally qualified health centers and other locations to help individuals sign up for coverage. We also have partnerships with Walgreens, with CVS, with Library Association nationally. So many ways individuals can find out about the marketplace. The Navigator program is actually available in all states. Some states, if they're state-based exchanges, are running their own programs. Nationally, we're running about 34 programs for those states that are federal programs. What the Navigators do is they applied for grants, they were awarded grants, they train individuals. These individuals will offer in-person assistance so that if you're having trouble understanding what's necessary to put together an application, if you need assistance in completing forms, they'll also be able to do it in different languages, just an additional way to help individuals. Well, obviously, we're very pleased that we've had the number of states expand Medicaid. For those who have not yet expanded, we will continue to work with them and show them actually the business case. Obviously, this is 100% federally funded for 3 years, and the lowest it ever drops is to a 90% federal funding. So what we're doing, we will continue to work with states. For those states that don't expand, we will help those individuals rely on some of the more traditional historical resources such as free clinics and others. You know, the way I look at the issue inside CMS, we approach everything, I call it the three-legged stool. There's quality, there's access, and there's cost. So obviously we just spent a little bit of time talking about the marketplace and Medicaid expansion, which really has to do with access. The second area is cost, and we have been able in the last 3 years to implement through the Affordable Care Act and other mechanisms ways to not only lower costs. We're at some of the best cost trends we've seen in the last 50 years, while at the same time improving quality. And a lot of the way we're doing that is through some of the pilots we have in the Innovation Center, where we are tying payment directly to quality as opposed to tying payment to the number of procedures done or number of hospitalizations. We're now focused on quality and tying payment and quality more closely together. You'll see that done in the accountable care organizations and some of our bundled payment initiatives, but it's kind of a new era for CMS. I think some of the lessons learned is that we've learned the importance of data and people getting timely data, and we've worked on that the last year. For those pioneer organizations that dropped out, many of them actually joined our more traditional shared savings program, so they'll continue to work with us on the accountable care organizations, just in a different method. But I think we're very pleased with the Pioneer program. We've already shown some early savings, and we'll continue to work with them and modify the program as we go along. There's certain areas where we've already begun that project. Obviously, we have hospital value-based purchasing, which actually began the program in October of last year. We also have tied payment and quality as it relates to rehospitalizations, but we'll continue to look at other areas where we believe you can pay someone for an episode of care versus for a procedure, and you'll be able to improve quality and actually lower cost. I think the goals of CMS will stay as I outlined. We'll be focused on access, we'll be focused on continuing to lower our costs, particularly cost per beneficiary. We know that the Medicare program is going to continue to expand rapidly. There's a large number of baby boomers. So how do we actually look at cost per beneficiary? And then we will stay focused on quality. I'm sure you're aware that globally, the United States still has some major challenges with everything from infant mortality to obesity to just longevity. So we'll be working on those areas.